Oh, sorry, I changed my mind.
Mike, are you going to be able to introduce? I'm not sure if Tyler really needs an introduction, but would you be able
Uh,
to introduce?
I am going to. I thought we'd give him another couple of minutes while people join.
Fantastic.
Yeah, and he certainly doesn't need any introduction.
Or want one.
Well, maybe I'll start with the introduction, Tyler, and I think people are starting
Sure.
to now.
Yeah.
I see Skinner's joining. So now that Dr. Skinner has joined, we can get started. So welcome everyone to the noon rounds. Dr. Tyler Smith is well known to most of the people here. And interestingly, he started his residency career in general pathology, but soon came to the realization that he enjoyed hematology or hematopathology more than general path. So our loss was hematopathology's gain. And now he is doing hematopathology, doing a mixture of lab management, flow cytometry, genetic diagnoses, etc., and completed a 2-year fellowship in thrombosis and hemostasis. And he's currently at VGH, and today he's going to be talking about ROTEM and TEG. Over to you, Tyler.
Thanks, Mike. So yeah, for those of you that aren't aware, we use ROTEM in the lab here, which is not a common way to do it. It's more commonly used at the bedside by anesthesia groups, but I'm going to go through the history of how that came to be and kind of the pros and cons of this test, which is kind of not outside of our normal conventional lab testing, or coag testing at least. Okay, so really, I don't have any relevant conflict of interest financially. And I am going to focus, though, more on ROTEM over TEG because that's what we use and I'm more familiar with. But a lot of these principles apply to both technologies. And really, I think it's important to acknowledge, too, that I do have mixed feelings about these. They're both more expensive than conventional tests. And in some cases, I don't feel like they really provide any additional value. But there are some instances that I'll highlight where I think there's a potential benefit to patient care. So when we're thinking of hemostasis, generally speaking, it's good to think of all stages. Things usually start off with a vessel injury, which results in kind of vasoconstriction to limit blood loss and initiation of primary hemostasis, where we have the von Willebrands, which are these little red dots, but in reality, von Willebrands is a very large multimeric protein. And that's kind of binding this exposed subendothelial collagen, resulting in platelet recruitment, which then change shape, release granules, recruit other platelets, and you form this kind of hemostatic plug. And that's kind of what initially limits blood loss, but it's not a very stable solution. And that's where we get secondary hemostasis, which happens on the platelet scaffold, and you get the formation of this web of fibrin, which stabilizes that platelet plug and results in a more permanent, or at least temporarily permanent, seal off of the wound. And then over time, when this endothelium repairs, you want this thrombus to be resorbed through the action of fibrinolysis. And so then you get clot breakdown and hopefully repair of your endothelium back to normal. Now, most of the lab tests we do revolve around secondary hemostasis, at least for coagulation testing. So things like INR, PTT, fibrinogen, these are all kind of focused on this secondary hemostasis aspect. But it's important to remember that hemostasis involves all of these aspects, and to some degree, ROTEM and TEG try to give you a bit more of a global picture. So in this secondary hemostasis coagulation cascade, classically, we break things down into the extrinsic and intrinsic pathways. When you get tissue damage, tissue factor that's released activates 7 and initiates the PT side, which goes through the common pathway, which then the thrombin formed then activates 11 and other factors on the intrinsic pathway, resulting in a large conversion of the fibrinogen, which is kind of soluble, to an insoluble fibrin clot. And if we wanted to kind of simplify this further, just because with all these Roman numerals, it can get a little bit confusing, you can just think about it using just normal numbers. And it helps to remember kind of what's in the common pathway, because then if you think of abnormalities in your PTT and your PT, you can use deduction to kind of work out where the abnormality might be. Like if both of them are prolonged, then you suspect a problem with the common pathway. And the common pathway contains 10, 5, 2, and 1. 2 is the other Roman numeral for thrombin, and 1 is for fibrinogen. And if you want to remember easily what's in the common pathway, you can just think of Canadian money. It's an easy mnemonic, because then all you have to do is remember that 7 is part of the PT INR side, and then all of 8, 9, 11, and 12 are part of the PTT side of things. So that's kind of our conventional kind of secondary hemostasis, at least in terms of what we teach medical students. In terms of how we test these, for sample requirements, we usually collect venous blood in a blue top tube, and that blue signifies that that tube contains sodium citrate, and that citrate chelates the calcium, which is involved in hemostasis, to kind of like arrest everything, all the coagulation factors in their inactive state. Because then when we want to initiate a clot, we can then add back in calcium. So this kind of arrests all the coagulation factors in their zymogen inactive forms. And we take this tube of whole blood and we centrifuge it down, which results in a large pellet of red blood cells, a small layer, which is hard to appreciate on this tube here, that contains buffy, or it's the buffy coat, but it contains platelets and white blood cells. And then this kind of straw or yellow colored supernatant, which is our plasma. And if a lab test is done on serum, you actually cause that plasma to coagulate on purpose so that you just have more of a clear, transparent, but obviously we don't want to do that with coagulation testing. We want it to be plasma. And generally speaking, we call this plasma platelet poor plasma because we've centrifuged away the platelets. So it's essentially an acellular solution. And tests must be run generally within 4 hours of collection, although we can freeze this plasma and run tests on it later if we want to. To make a sample clot from this plasma, we need to add back in phospholipid because we removed the platelets. You have to add back in calcium and an activator. So in the case of doing the PT, which is converted to an INR, we add tissue factor, and the clotting time is usually around 12 to 15 seconds. And for the PTT, we add a contact activator, which is some kind of firm or hard surface like silica or kaolin, which stimulates factor 12 on the contact side. And the PTT goes through more factors and it takes longer to clot. It's about 30 seconds. So in terms of these conventional tests, the good about them is they're widely available, they're automated, they're very quick to perform. Generally speaking, if we're only waiting kind of 10 or 30 seconds for clotting to happen, it's a pretty fast test. The reagents are kind of widely available and quite inexpensive. If you look at the consumable cost per test, it's about $1 per test. And clinicians are familiar with these tests. We've been using them for kind of over half a century now. So they're, kind of embedded in medical decision making. The not so good though, they do only assess parts of coagulation, like even within secondary hemostasis or the coagulation cascade, they still only give you part of that process each, the INR and PTT, although we kind of use them together. And they don't actually even assess the inhibitors very well of coagulation. And they also don't assess primary hemostasis or fibrinolysis, which on my first slide kind of are also important in hemostasis. And also, from a technical standpoint, there's many different reagents and instruments used for these tests. So the comparability is sometimes challenging between, like, you might get the same patient getting different results at different labs. And they're really kind of optimized for monitoring the more traditional anticoagulants like heparin and warfarin, but really weren't designed to assess, kind of, a rapidly bleeding patient if you wanted to kind of decide on transfusion therapy. They're maybe not optimized for that purpose in the same way they are for monitoring anticoagulants. So for these reasons, there's always been an interest in something that's a more global hemostatic test. And the term that's often used is whole blood viscoelastography. Mike, if you don't mind muting, or maybe Eunice, I think I'm picking up some background. And so the potential advantages of TAG and ROTEM is that they are point of care tests, so they could be used at the bedside. And I think that's how these tests started in the anesthesia world, because they were often used in ORs at the bedside. They certainly like to promote themselves as being more physiologic, in that, as opposed to using this kind of centrifuged plasma that removes red cells and platelets, these tests are done on whole blood, so it's kind of felt to be more representative of like what's actually going on in the vessels of patients. And they also are kind of touted as having, as like not just looking at secondary hemostasis, but also looking to some degree at least at primary hemostasis and fibrinolysis. And so the idea is to try to say, in a bleeding patient, does this patient clot normally or not? Because if they have a normal profile on ROTEM, then the focus on the bleeding should be the source of the bleeding, not necessarily trying to replace with plasma or other things. Obviously, you might need to keep up with losses, but the primary issue might not be, a lack of fibrinogen or a lack of platelets. It might be just simply that everything hemostatically should be normal, but there's some other reason why the patient's bleeding, such as, an unligated vessel or something. One other thing about these technologies is they do provide a visual depiction, which I'll go through with you. So instead of just giving a numeric result, maybe for in the emerge, when you've got a trauma patient who's in a large major hemorrhage, maybe just seeing a very flat curve on a screen that kind of, really screams that this patient needs more fibrinogen is more effective than simply a numeric result that just says low fibrinogen. And the aspect that I kind of already mentioned, fibrinolysis, is that, these aspects of coagulation, which are often ignored in regular INR and PTT, are at least partially captured with these technologies. So TEG was the one that has the longest history. It dates back to the 40s. And there's kind of different activators that are used in different generations of it. But the underlying technology hasn't really changed that much. Essentially, what you have is a sample of whole blood, and it's in this cup, which oscillates back and forth by just like kind of 4 degrees or so. And as a clot forms, there's resistance to this oscillation, and that's depicted numerically. ROTEM is essentially the same kind of thing, and this is an example of one of the ROTEM devices we have in our lab right now. The only difference is, instead of the cup rotating, the pin is rotating, but it's a similar thing where it's basically about 5 degrees, and you're just measuring resistance when the clot forms. So this visual depiction is moving time left to right. And so initially, the amplitude is what we'll focus on here. And the units are kind of arbitrary. They don't necessarily mean anything in terms of how we relate to our other coagulation tests, but they do have normal ranges for all the measurements. So CT, or clotting time, is the initial part where there's no kind of increase in amplitude or no resistance yet. Generally, in terms of timing, it takes about a minute for that. And then you start seeing an increase in amplitude or resistance. And then there's parameters like alpha and clot formation time, which are used, but we don't actually report these. But eventually you hit a point after 10 minutes where you get an amplitude, and this A10, or amplitude at 10 minutes, is one of the parameters we use. You then reach a maximum amplitude, and then, and then over time, this just continues out indefinitely. And so this shows you more of the parameters, but I should point out that this is not a normal clot. What would be expected normally is for this to continue straight, and I'll show you examples of normal. Whereas if this were to go back down like this, almost like this fish kind of profile, this would be hyperfibrinolysis, where you basically form this clot, and instead of it staying around indefinitely, it gets lysed before the 1 hour of analysis is finished. So the parameters we report are clotting time, which is kind of like your INR or PTT, depending on which activator you use. The amplitude at 10 minutes, which takes into account fibrinogen and platelets, and then your maximum lysis which is the lysis after 1 hour of analysis. There are other parameters, and we keep track of these, but we don't report them because we don't necessarily want to make it more confusing than it has to be. And I'll show you some of the algorithms we use. So we just use two channels, XTEM and FibTEM. XTEM uses a tissue factor activator. So it's kind of like a PT-INR, where you're kind of initiating things at the tissue factor 7 area and then measuring the clot. And then the FibTEM is simply the same thing, but you've also got a platelet inhibitor present as well. So you kind of see the same process, but without the platelet effect. So if you see kind of, for instance, a bad amplitude on XTEM, but it is fairly robust on FibTEM, then it suggests that the fibrinogen is not the problem, but rather it's the platelets. But I'll get into that more. There are other options for channels you can use. There's an APTEM channel, which is essentially tissue factor again, but it also includes a fibrinolytic inhibitor. So if you saw increased fibrinolysis like this here, the idea would be is you'd have the APTEM channel also running the same analysis, but with an inhibitor of fibrinolysis. And if that does reverse that hyperfibrinolysis, then you'd get that clot would look much more normal, or at least the profile. And then INTEM is essentially like a PTT, obviously using whole blood, and it uses a contact activator. And then the HepTEM is the same as the INTEM, but with a heparin inactivator. So essentially kind of neutralizing the heparin. So you see what that kind of INTEM would look like if there's no heparin. And so those might be used for cardiac surgeries, but in our institution and most institutions, they used another test for monitoring the high levels of heparin used in cardiac bypass. They use what's called the ACT, or activated clotting time, and I'm not going to go into that. So there's all sorts of algorithms that generally all have the same kind of principles behind it. This is an example of a normal XTEM clotting profile. So unlike the one I showed where it became a fish kind of profile, this kind of stays out at a nice robust amplitude for the whole time. The clotting time is quite short, which is normal. So you basically have a normal clotting time, normal amplitude, and you don't have fibrinolysis. And the FibTEM normally kind of stays in this pink zone. And so this is kind of what we expect for an XTEM FibTEM profile. So if you had somebody with this profile and ongoing bleeding, most likely there's not an issue to do with coagulation factors, but more likely a surgical hemostatic problem. And then for other examples of abnormalities you might see, so in this case, we've got low amplitude of both the XTEM and the FibTEM. And so because the FibTEM is the one that's really dependent on fibrinogen, if that shows low amplitude, then your main issue is low fibrinogen. So you give cryoprecipitate, although now we just give fibrinogen concentrate. If that initial clotting time is prolonged, like that green line, then, like I said, this is like an INR, this part of things. So you'd kind of be worried about low coagulation factors. And generally in a massive transfusion scenario, you're just going to give frozen plasma. Although in some European centers, they might give concentrates of some of the vitamin K dependent factors, which is called PCC, or prothrombin complex concentrate. But the idea is you're replacing the missing coagulation factors. And in this case, this is the scenario I kind of alluded to, where your FibTEM amplitude is normal, but your XTEM is low. And so it suggests that your fibrinogen is just fine, but maybe there's a problem with primary hemostasis, and you might need to give platelets. And then in the case of, this is that kind of fishtail profile where, again, or basically you have this abnormal increased fibrinolysis, and this is that APTEM channel where it normalizes. So in this case, if you haven't already given a fibrinolytic inhibitor, you would definitely want to get on that urgently for the patient. And this is a widely used fibrinolytic inhibitor that's available in pretty much all centers. Now, so we kind of started thinking about ROTEM in the lab, or even at VGH, around this time, 2016. And the reason we did was publications on TAG, which is in gray, and then ROTEM kind of had exploded kind of in the early 2010s. And so we basically were having the discussion with our colleagues in ICU, in trauma, and in cardiac surgery about is this a technology we should be using? And there was already some studies supporting its use. Now, if you actually look at um, kind of uh, kind of aggregate studies like a Cochrane review or a meta-analysis, generally speaking, there's a lot of concern about these single center studies where there's basically a risk of bias because there's publication bias. Generally, people are kind of either publishing these studies because they want to promote these technologies or kind of they're looking for uses for them. So they're maybe not as robust as, say, like a proper controlled trial where you're kind of randomizing one group to a ROTEM tag algorithm and another group to something like just kind of standard care. So generally speaking, for trauma, the feeling was that these should be used for research use only, and they're really not standard of care. And I've looked, and there hasn't been a more updated review of these technologies. So this is still the most recent Cochrane review. And then when they looked at bleeding patients in general, there was actually more evidence in the cardiac surgery population, and some of those studies are actually Canadian, which were organized by Kevin Karkouti and the Toronto group, both initially locally, but then they also did a Canada-wide study. And so even though these studies showed improvement in terms of blood product usage, there was still a feeling that the further evaluation is still needed. And really, outside of cardiac surgery, there really wasn't a lot of strong enough evidence to support their use as standard of care. There's also concerns there's been a few studies that have looked at TEG and ROTEM compared to each other and showed that they do show some discordance. And any point of care lab test is limited by laboratory accreditation requirements because you have to decide, who's going to be operating, who's going to be looking after it. So when it lives in the hospital lab, it's a little easier, well, a lot easier to control these variables. You can have kind of trained staff, you have proper documentation of your quality control and external quality assessment activities. If there's any problem, you can troubleshoot it, and the techs are used to doing this. If you're using this out on the wards, it might be a nurse, or in the ORs, it might be a perfusionist that's using these, and they might be less familiar with kind of how to operate machines and troubleshoot them when there's problems and do the necessary quality checks. So that's obviously a concern with any kind of point of care device, especially more complicated devices like these. The results may not be as fast as you hoped. So even if you're using it at the bedside, you still have to do some pipetting. And so even though you don't have to centrifuge the sample, centrifuging the sample for conventional coags only takes about 5 minutes. And so that if you're having to manually pipette, because our conventional tests are on automated machines where you just load the tube and it goes right on. So if you have a tech now having to pipette, that does take a few minutes. And then if you want to do the full assessment of fibrinolysis, you're having to wait that full 1 hour to see that full assessment. So even though you get early assessment of that clotting time within a minute and the amplitude at 10 minutes, if you want to look for a full assessment of fibrinolysis, you're waiting up to an hour. And if you look at the consumable cost, the combination of XTEM and FibTEM is about $60 versus $2 for getting, say, an INR and fibrinogen. So obviously you want to limit, and for a one-off, this doesn't sound like that much money, but when we're talking about hundreds of tests, then it starts to add up. And obviously, anytime we can get the same information with conventional tests, that's from a resource standpoint much more sensible. Now, in terms of what are the areas where we might want to be using ROTEM or TEG? And these would be areas where there's at least some evidence that conventional coag tests are maybe not giving us the full picture. So there's concern with cardiac surgery. One of the concerns is platelet dysfunction, because a lot of these patients will be on platelet inhibitors or be on kind of circuits that can inactivate platelets. There's this entity called acute traumatic coagulopathy, which is, when you have somebody who comes in with, say, massive blunt tissue injury, where you've got a systemic increase in tissue factor and activated protein C, which is an inhibitor of coagulation, and maybe even activation of fibrinolytic mechanisms, as well as kind of losses of factor 5 and fibrinogen, which admittedly conventional tests would detect, but there's some studies that show that some, factor V isn't really well detected by conventional tests, and these aspects really wouldn't be assessed much at all. And so this idea of trying to better assess massive trauma patients in terms of their coagulopathy and better resuscitate them to kind of improve their survival chance. Patients with liver disease, which is certainly a common population in our hospitals, is that, oftentimes the INR is quite high in patients with liver disease. And that's because the INR is really reflective mainly of those procoagulant factors. But in liver disease, you're also, even though the liver makes most of your procoagulant factors, it also makes most of your anticoagulant factors. So there's this concept of rebalanced hemostasis where with liver disease, yes, your INR is quite high and looks like, similar to somebody on warfarin, but those patients don't tend to bleed the way somebody at a high INR on warfarin is. And generally speaking, it's probably because you also have, everything is at lower levels. So the INR is probably not representative of the patient's kind of general balance in terms of bleeding and clotting. And so there's some evidence that I'll show you actually that ROTEM and TAG may give a more realistic picture of this. Conventional tests really aren't really designed for primary hemostasis assessment, at least not acutely. Certainly we can do a platelet count on a CBC, which gets done acutely, so you get a platelet count. It does not assess platelet function, and also von Willebrand's factor, which I kind of mentioned is also part of primary hemostasis. We don't really assess for acutely. We do test that on patients where we have time to kind of send it to specialized labs to do the testing, but it's not something that a trauma patient coming in is getting von Willebrand's levels done. So the idea is at least ROTEM gives us some information about this primary hemostasis. And then fibrinolysis, really, we don't assess pretty much at all with conventional tests. And it's something that if it's present, we have a readily available treatment in tranexamic acid. And then, of course, there's patients on extracorporeal membrane oxygenation or ECLS. Like these are kind of circuits for ICU patients who these circuits either bypass the lungs or the lung and the heart. Sorry. And the coagulation assessment of these patients is often kind of controversial, and some people have put forward using ROTEM and TAG to monitor these patients to assess, do they need to be on a heparin drip or other things in terms of they're like basically making sure the circuit doesn't clot. So in terms of where these devices should live, traditionally they have been used point of care, and that's where a lot of centers still use them. The Canada-wide cardiac study used them point of care in the ORs. And the advantages are obvious in that you don't have to transport the sample to the lab. You can use it right at the bedside. There's also maybe an argument that if you have the machine right beside the patient at the bedside, then the clinical team is going to be more aware of the results because the machine's right there. And in terms of lab-based, there's considerably more advantages. It doesn't to say that that's the right solution for places that are going to use these devices, but some of these advantages would be that obviously your user training competency assessment is simpler because we're doing that for all our lab staff are operating many instruments. There's also simplified training assessment of the operators. The results can be streamed live to all wards. So really, like, in our trauma bay, for instance, we have these large, and in the ORs, these large screens that display the results. So they can display the ROTEM profiles in real time as we're running them in the lab. So whether you actually have the device there is maybe less important. There's also an argument to be made that, given that these are often massively bleeding patients, having the sample run in the lab where it's kind of, quieter and calmer, there's going to be less distractions, less problems with, say who's ever setting up the device, maybe they'll, won't forget if they pipetted the right reagent in the right tube. It also becomes easier to integrate the results into your lab information system and your patient care information system. And then also quality control and external quality assessment is definitely simpler if it's done by lab staff that are doing this for all of our tests, not just these tests, as opposed to kind of some of the ward staff where they might be less familiar with how to do this. So at VGH, we kind of started down this road between 2014 and 2015. And initially, we actually just did a pilot study in trauma where we basically ran the XTEM and FibTEM in parallel with routine coags. And we had a flasher system so that when samples hit the lab, normally when the lab sees a blue top, we immediately centrifuge it, but we needed to like flag these samples that they're not to be spun down and instead to be Ranstat on the ROTEM devices. And really we wanted to see whether ROTEM provided additional value in managing trauma patients. We had a protocol, which I won't go through, but it basically used the parameters to help direct blood product usage. But in general, like it was also highlighted that there's still clinical judgment involved. And in terms of what we learned, initially there were some pre-analytical challenges in terms of communication to the lab, but from the trauma bay, because we wanted them to give us a warning when these patients were coming in, especially because some of the reagents need to come out of the fridge and need a few minutes to come to room temperature before you can run it. But in terms of the actual analysis, things went pretty smoothly. The turnaround times were initially worse in conventional tests, but then, and that seems kind of counterintuitive because you don't have to spin the samples, but I think because it was a new test, a new procedure, initially things were slower. But in the end, and also our conventional tests, what I haven't highlighted is in these acute settings like trauma bay, emerge, and ORs, our lab, even though we deal with samples from all over the hospital, the samples coming from these acute locations are prioritized, so they jump the queue. So they're treated as kind of stat samples as they are. So generally speaking, whether you're doing a ROTEM or a conventional test, it's about 45 minutes from blood draw to the sample actually giving results. And generally speaking, the information we got in most of the trauma patients was redundant. It was basically showing the same information we got from just doing an INR fibrinogen, which are kind of our conventional tests. But we did see that there was mild abnormalities, especially in fibrinogen, detected by ROTEM, especially that FibTEM amplitude would be a little bit abnormal on the ROTEM. But if you looked at the conventional fibrinogen test, like the normal cutoff is 1.5 and above is normal. And in this case, if you looked at the low end of that normal range, a lot of these had abnormal FibTEM profiles. So you could argue that, you know, maybe our fibrinogen threshold is you know, a little bit high, or maybe this is overly sensitive. And it's always hard to know, but generally speaking, it was flagging some of these borderline low fibrinogen samples. So maybe that's a good thing in trauma where you want to make sure you don't get behind the patient in terms of resuscitation. But it's still of kind of questionable value of whether these devices are really worth it just for this. In terms of platelet dysfunction, we really didn't pick up much of that. Granted, that's not really as much of a concern in trauma anyways. Generally speaking, the patients are more have problems on coagulation rather than platelet function. And really, we only had one case that showed a hyperfibrinolytic profile, which, you know, if we're detecting a lot of this would be a big concern, but there's just one. And this was somebody who was basically dead on arrival where there was no kind of chance to resuscitate anyways. Now, surgeons did report, the trauma surgeons did report to paying more attention to coagulation results, which is, you know, for those of us in the lab, I think a lot of times you feel like surgeons don't pay enough attention to lab tests. So this was a positive. But really, our study wasn't really powered to assess any impact on transfusion medicine service inventory. So some interesting results, but maybe not clear as to whether it's actually worth using all the time in trauma. But around this time, the cardiac study across Canada had really kind of had its data come through. So we had numerous groups in the hospital, so cardiac anesthesia. And because VGH is a large liver transplant center, we had liver transplant anesthesia also interested in this, especially this concept of rebalanced hemostasis, because we're seeing that the liver transplant surgeons ordering tons of plasma in patients who hemostatically didn't seem like they were bleeding that much. And so there's concern that we are over-treating the liver transplant population. And obviously trauma surgery was still interested in it, even despite the kind of more limited results we had. ICU for the ECMO patients. And then we had representation from the lab, and we had a project manager from VCH that really kept things on track in terms of the group meeting on a regular basis. And we also involved some industry representation when we needed technical input about what the technology's capabilities were, especially in terms of integrating with our lab system. So we basically rolled out lab-based ROTEM in fall of 2017, where we had 2 machines. Each machine has 4 channels, and so if we're running XTEM and FibTEM, we could run 2 patients on each machine. So with 2 machines, we could run up to 4 patients simultaneously, with the results streamed live via the hospital intranet. So it's a secure, it's not like somebody's going to be able to view this on the web externally. And following the 1-hour run, the numerical results are dumped automatically into the patient care and lab information systems. So they stay in kind of perpetuity. You just lose the actual curves, but you get the numbers kept long-term. And then ordering locations, just to limit utilization to the acute centers that are supposed to be using it: Emerge, OR, cardiac, CCU, and ICU. And so our algorithm, which I'll go through a little bit more here, is kind of similar. This is for ICU, but this similar kind of principle applies for the different applications like cardiac surgery, where basically if it's outside of normal kind of, if it's like graveyard shift kind of hours, they should call the lab just to make sure that we have the analyzer ready, just because things might not be running as often at that time. But the patient has clinically significant bleeding, do the usual optimization where you make sure the patient's not overly anemic, their temperature's kept up so they're not in that kind of cold coagulopathic state. They have adequate calcium for coagulation and they're not acidotic. And so if those are satisfied and the coagulation results should be valid, then we run the ROTEM. And so if we see a low amplitude on the FibTEM, you optimize fibrinogen with fibrinogen concentrate. If you see a good amplitude on the FibTEM, but a low amplitude on the XTEM, you give platelets. If you see a long clotting time, then you give coagulation factors in terms of plasma. And if you see hyperfibrinolysis, you give TXA. And so it's kind of just similar to the algorithm I'd already showed you, but this is the one we use here at VGH. And in terms of the utilization, by far the largest user is cardiac surgery, liver transplant, less so trauma and ICU. Although the ICU usage did go up certainly during the COVID pandemic. And in terms of the utilization, even once we first rolled it out, numbers had already gone up significantly. And now we're kind of hovering kind of more like around 250 to 300 tests per month. So definitely it's a lot more uptake with a similar number of patients. And I think that's largely showing that once people got used to using it, they were kind of doing more follow-up testing. And to some degree, that's appropriate because you want, if you see abnormalities on the ROTEM, then you want to, and you give, say, plasma or fibrinogen, you want to see, does that improve things? In terms of the ordering location, most of the ordering was coming from ORs and ICU, and most of these ICUs were post-OR cases. So when you looked at the service ordering it, cardiac surgery was the largest one, liver transplant, fairly significant, much less in trauma and other services. And then Jackie Trudeau did a little pilot study where we looked at the actual timing of everything. And we found that on average, between sample collection at the bedside in the OR or trauma bay to receipt in the lab was about 7 minutes. And then we couldn't actually, there's no time recorded for when the samples actually like started on the machine, but we do know the time that the data results at the end of the run are dumped into PCIS, and we could work backwards because that analysis should be 1 hour plus the clotting time, which is usually about a minute. And so if we work backwards, we get about 8 minutes on average from being received in the lab to starting the run. So you're basically taking from sample collection to starting the analysis, 15 minutes. And then after that, you're just watching the curve. Yeah. And so in terms of what's it useful, so actually, I think that should be spring of 2008. Basically, 6 months after implementation, the cardiac and liver transplant anesthesiologist universally felt that there was some positive impact with ROTEM. And admittedly, this is subjective, but this was more just a sense of, are the clinical users happy with this added service? They felt that it improved their understanding of hemostasis. They said it often changed the type or amount of blood product they were using. And they said that it often led to less product usage subjectively and improved ability to manage bleeding patients. And generally, we're happy with the turnaround times and the results display. So in terms of cases, I'm just going to show you a couple of quick cases. This is one case. It's a trauma patient who basically was waving a machete at metro station, obviously not a well person. He was shot in the abdomen by police, and the gunshot wound was in the upper abdomen, left of the midline, with an exit wound near the spine. He actually underwent cardiac arrest at the scene, but they had return of spontaneous circulation with CPR, but obviously he was clinically unstable. When he got into the hospital, he did have a palpable femoral pulse. Heart rate, which is normally less than 100, was 135, so was showing signs of shock. And the trauma exsanguination protocol was activated, where we give a lot of blood product even before lab tests come back. Once we did have lab tests, our conventional lab tests were fairly normal. This is INR of 1.2 or less is considered normal. PTT up to 38 seconds is normal, and fibrinogen above 1.5 is normal. So basically the fibrinogen slightly below normal, and these two normal. But when we looked at the ROTEM profile, we saw this increase in fibrinolysis. Normally, this should be less than 10% in normal individuals, and here we had 63%, where of the amplitude reached here, we've lost already about 60% of it by the end of the analysis. And so this even though the trauma patients already get TXA, additional TXA was given to this patient. And on top of that, the low amplitude of the FibTem prompted giving fibrinogen, which I guess would also be supported by our low fibrinogen. Generally, this amplitude should be 10 or more. And so this patient got TXA, and I think this is before they got the fibrinogen reconstituted. So initially they just gave with the trauma protocol, red cells and plasma. But I think the need for fibrinogen, and I should say plasma does contain fibrinogen as well, but just not as much as fibrinogen concentrate. So this patient went to the OR, estimated blood loss was 5 liters. The total time in the OR was 2 hours, and anesthesia was doing ROTEM-guided resuscitation. And if you look compared to the previous analysis, you can see that fibrinolysis has pretty much gone away. The lysis is less than 2%, so in the normal range, but we still have a low amplitude. So this is somebody who should get more fibrinogen. And then with ongoing resuscitation, we saw the same pattern, not enough fibrinogen. And so this was still in the days when we were using cryoprecipitate more than fibrinogen, and this is a plasma product which is enriched for fibrinogen. And basically with that focus on giving, and this is an interesting one where later on during the resuscitation, the conventional fibrinogen was now normal. It's well above 1.5, but we're still seeing a low amplitude on the ROTEM. So this is one of these trauma cases where maybe this is giving us a signal that the patient might need more fibrinogen. Again, it's hard to know for sure because we don't have a gold standard to compare to, but generally speaking, they felt like it was on balance better to give the patient more fibrinogen, which eventually normalized that amplitude above 10. And so at this point, they gave platelets, I think, just because the patient had this still slightly low amplitude of the XTEM despite a normal FibTem. So that's that platelet dysfunction thing. Unclear if this was actually indicated or not. But in any case, they did close the patient and did not require additional blood products. And with the assistance of the clinical guideline, the clinicians felt that the ROTEM did help with the resuscitation. The second case I'll present, and then I'll leave 10 minutes for questions, is a liver transplant case. And this is a patient who had non-alcoholic steatohepatitis for liver transplant. So this is where they have end-stage liver disease, but not related to alcohol or hepatitis. And in this case, this patient had an INR of 1.9, so normal is 1.2 or less. Fibrinogen was just, again, slightly low. Platelets are a little bit low. Hemoglobin's a little bit low. So nothing dramatic, but the most noteworthy is the INR being kind of almost twice normal. And this patient actually, this isn't always done, but this patient prior to the operation, because it was felt like they would need a lot of blood support, they actually, before the OR, took off about 1 liter of the patient's blood with the intent to give it back to them. And so this obviously worsened the coagulation profile now. So the fibrinogen was 1.2 and the INR is 2.2. But the ROTEM, what was interesting is it showed the expected low amplitude on the FibTem, but it also showed borderline hyperfibrinolysis, just barely 11%. But this is a population, like in trauma, it's very common to give TXA for antifibrinolytic therapy. But in liver transplant, that's never on anybody's radar. And so this was a case where with this information, they actually thought, well, why don't we give TXA during the liver transplant? And they did give some fibrinogen concentrate because of the low fibrinogen, but the INR of 2.2, remember how I said that the clotting time, the CT, is the comparable to the INR. In this case, the clotting time is normal. This is within normal limits still. And so this is a case where this kind of quote unquote rebalanced hemostasis of liver disease might be actually happening, where the ROTEM might be giving us a profile that's more in line with the patient's kind of actual in vivo hemostasis than the INR. So a lot of times this patient would have been given plasma prophylactically, but in this case, they only gave fibrinogen and no plasma. And then during the OR with the TXA infusion, the maximum lysis normalized, so the fibrinolysis went away. INR is still elevated. Platelets and fibrinogen are okay, but we do see this slightly low FibTem amplitude. So you could argue that maybe they should have given fibrinogen here. For the time being, they just continued the TXA infusion and didn't give any plasma. And again, this clotting time is normal, whereas the INR is elevated at 2.3. So there's this discrepancy where the anesthesiologist was going more off of this clotting time than the INR, and so did not give plasma. And now this is 15 minutes post-reperfusion of the transplanted liver. We still see the low amplitude and the normal clotting time. And so at this point, they continued TXA, gave fibrinogen concentrate, and then because the patient is anemic at hemoglobin 82, they gave back some of that patient's own blood that they'd collected preoperatively, as well as cell saver blood, which is a device in the OR where they can collect some of the blood lost by the patient and give it back to them in a sterile way. And then basically close to 2 hours post-reperfusion of the liver, you see the INR here is 2.7, yet that clotting time is still normal. We've got a good fibrinogen amplitude of 12. So really, from a ROTEM standpoint, everything looks totally fine, even though that INR is 2.7, like quite elevated. And so they did not give any blood product. And so during the entire OR of the liver transplant, they gave 8 grams of fibrinogen concentrate, which is still a human blood product, but it's processed to be safer than plasma and generally speaking would be a kind of safer product to give a patient. Got a bit of albumin, crystalloid fluid, the TXA, but they did not get any exogenous red blood cell transfusions and no frozen plasma given. So they only got their own blood back, as well as the fibrinogen concentrate. And post-op day 1, the patient's INR had already improved to 1.5, and the next day was 1.2, and the platelets were close to normal. So this patient didn't need any further blood products. And so this is a patient who had an INR that ranged between 2 to 3, who basically didn't need any plasma despite a bloody liver transplant surgery. And so a few words of caution: these 2 cases are cherry-picked since they highlight the potential added value of ROTEM, and there's really no true gold standard for normal hemostasis to adjudicate discrepancies between our conventional tests and our ROTEM tests. And given the complex and heterogeneous nature of bleeding surgical patients, it'll take large studies to properly evaluate the impact of these devices. And so I don't think by any means they should be considered standard of care just because sometimes they seem to come in handy. And before you even consider these in your center, these are all questions you have to ask: where the device is going to reside, who's going to run them, who's going to train and evaluate the people running them, who's going to do the quality checks, who's going to pay for the devices and the reagents. These are expensive tests. How will the results reach clinicians? How will they be stored? What are the IT barriers? Who are the stakeholders that need to be involved? Clinical indications, and how are you going to ensure that people are actually following these clinical indications, and how you evaluate its clinical utility? So these are all important questions that apply to any lab test, but especially tests like these where they're quite expensive and technically complicated to run. So I apologize for only leaving 8 minutes for questions, but that's the end of my talk. Thanks.
Thanks very much, Tyler. Very interesting. It seems to have gone a long way since I used to do those or view those platelet aggregometry studies with, I don't know, things like ristocetin cofactor.
They
I don't
still
know.
do those. They still do those, but not in bleeding patients, obviously.
Okay,
Yeah.
fair enough.
Mike, weren't you the king of the ESR?
That's one that we've mostly gotten rid of. It's still like, yeah.
The ESR, an underutilized test.
Yeah.
Anyways, question. Thank you very much, Tyler. Very interesting. Questions for Tyler?
I've got a couple. First of all, terrific talk, Tyler. I missed most of this because I'd sort of left the premises before this exciting advance.
This you just missed this, Cedric. Yeah.
Anyway, a couple of things. As I understand it, you will get the point of care ROTEM results into the basic lab base at the same time, so you can see what's happening, or not?
Sorry, do we look at conventional tests and the ROTEM?
No. You see, the ROTEM's been done on site, not in the lab.
So we're running it in the lab.
Oh, I see. Okay,
But other centers are doing it at the bedside.
Does it get into the lab database? Or
yes.
Not?
Yeah.
Okay, that's terrific.
Yeah. But it's just the numerical parameters.
Okay, got that.
We only put in the key parameters for the algorithms, so the clotting time and the amplitude and the lysis. We store the other parameters internally in our lab system, but we don't release those into the patient system because we don't want to overwhelm people.
I'm with you there. The fibrinogen levels, one was a bit discrepant. I think if you've got a lowish fibrinogen and very high FTPs, you're going to get a discrepant result, which you're obviously up to speed on. It struck me in the right circumstances, although it costs a bit of money, it could earn its keep in terms of being economical in terms of blood products. And I think one of your examples showed that.
Yeah. And Jackie Trudeau and others have looked at the blood product usage since we implemented these. I didn't really have time to get into it, but in the cardiac population, you see much less, and liver transplant, much less plasma usage.
Right.
You do tend to see more fibrinogen usage.
So it's the less blind leading the blind, or vice versa.
Hopefully, yeah.
Okay. The other thing is, it's obviously more up to speed than most places in VGH. Anyone else in the province using it? For example, those aggressive chaps in Victoria.
Well, I think a lot of places are using it. The anesthesiologists are using it for cardiac surgery patients. But I think there are some centers, and I've had Nick Au from Children's reach out to me, and because there's their fetal maternal hemorrhage and what do you call it, post delivery hemorrhage. Sorry, because we don't deal with maternity stuff here. I forget the name for it, but postpartum hemorrhage. There's some interest in looking at it there. And then also, I think Fraser has been considering having it based in the lab, or at least having some cooperation between the OR and the lab in terms of these devices.
Yeah, the only other thing, it's small print. I did actually start to look at some bits, trying to see if we could look at dysfibrinogenias that were resistant to normal fibrinolysis for hypercoagulable cases. That's small. Anyway, look, congratulations, Tyler. Splendid talk.
Thanks, Cedric. Yeah, and I see Michelle Wong in the chat confirmed that there are ROTEMs in the cardiac ORs.
Interesting. And
Nick Sunderland Kelowna's got 3 tags in their ORs. ICU has 1, as there was a single intensivist champion in the setting, no lab-based ones. The other thing I encountered in some some of the clinical services, like the surgeon, some people saying, well, now that we have ROTAM, we don't need to do INR and PTT. And I'm like, no, keep doing INR PTT, because we want to really limit the ROTAM to where it's actually going to be useful. In a way, we need that comparison if we're going to do studies looking at added value of the devices.
Excellent. Any other questions for Tyler? I guess my interest, maybe David Hunson's more acquainted with this test, but any appetite for reintroducing the bleeding time?
So for those of you that aren't aware, bleeding time is where they basically take a razor and slice patients' forearms and see how long it took to clot. Apparently they still would do them in McMaster a while back. I don't know if they still do. Yeah.
Well, Cedric moved here.
I just had a question. If
Hey,
there's
Eunice.
more time. Hey, yeah. So they still
Yeah.
do actually the bleed-in time in Edmonton. There's one.
Oh, they
person
do.
that-
Okay.
Yeah,
I
that
didn't know
loves
that.
it apparently. Anyways, but global assessment of thrombo.
At least it's
yeah,
primary
that's what-
hemostasis,
that's what
right?
it's
The
sold
bleeding
as.
time.
Yeah, primary. Anyways, but so I know that your ROTAMs are in the OR. In the lab.
Yeah.
Ours are in the OR, and sometimes I get into situations where we get product requests, particularly platelets, but we're not, and we're told that it's based on some of the parameters. I don't know if you're looking at the MA or what have you.
Yeah.
But sometimes I don't know if they have particular triggers or if it's based on the clinical context or what it's based on. So I'm just wondering, have you ever had to negotiate those conversations?
So that's a good question. We have, I think our rules are if clinicians order platelets, especially from these acute settings, unless they're ordering an inordinate number, like if they've ordered something like 4 or 5 doses of platelets, then if it's just 1 or 2 doses, we don't screen those. So even if the patient has kind of quote unquote normal platelet count, generally speaking, if it's from the OR or trauma, we'll still issue it. Although there is some tech some tech judgment involved. If they feel like this is something where it's doesn't seem to make sense that this patient's getting platelets, then we might call the clinician and have the discussion, and then obviously they might kind of explain to us what the ROTAM might be showing. What I have generally told our hemopath on-call group is our group's not responsible for like interpreting the ROTAM curves. That's the clinical team's judgment. Like they're supposed to be judging the ROTAM results. We should have a basic understanding of it, but we're not going to, if there's something unusual on those, I don't expect our hemopath on-call group to necessarily weigh in on that. But certainly with the platelet dysfunction thing, if it's just a dose of platelets and it kind of matches our algorithm, then we usually just will issue it, and it hasn't really been an issue. Like